Okay, we are live.
Hi everyone, welcome back to another virtual shadowing session with Pre-Dental Universe. We have an exciting presentation today with Dr. Pierre, who is an oral and maxillofacial surgeon. Today, he will be teaching us more about his experiences and in dentistry and in the field. So on that note, feel free to take it away whenever you're ready, Dr. Pierre.
All right. Good afternoon, everyone. Again, I'm Dr. Pierre. I'm an oral and maxillofacial surgeon. I'm currently practicing in the northern central Florida region with Aspen Dental. So thanks for having me today. And just a brief outline of what we'll kind of go through today. We'll just talk briefly about myself and how I got to this point. And then I want to give you guys a little intro into what oral and maxillofacial surgery is and why OMFS was a good career path for me and why it may be a good one for you as well. And then we'll go through a couple of patient cases, 3 or 4 cases, just to give you a little insight into the field of oral surgery, and then we'll wrap it up with some Q&A, and then pretty much the process. We can discuss the process of going from dental school and beyond into a surgical specialty. All right. So a little bit about myself. I was born in Brooklyn, New York. We pretty much left like a year and a half, 2 years later, and we went straight to Orlando, Florida. So I grew up most of my life in Orlando, Florida. While I was here, I went to Lyman High School, and I was in the Engineering Institute program. So funny fact, I initially wanted to be an engineer, but that kind of changed, after high school once I got into undergrad. And at Emory University, that's where I got a bachelor's degree in economics, which is kind of a little deviation from the norm. Most people majored in biology or chemistry. So I thought that stood out a little bit. After Emory University, I went on to University of Florida College of Dentistry. That's where I earned my doctorate degree. And I don't know if any Gator fans out there, but go Gators. And then after dental school, I went on to Brooklyn, back to Brooklyn, essentially, where I matched into the Brooklyn Hospital for oral surgery. In that program, while we were there, we got the chance to rotate at various different hospitals, which was good because you got a chance to learn under different attendings and gain different experiences. So some of the hospitals listed here, the Brooklyn VA Hospital, so you get to treat a lot of military veterans. St. Barnabas Hospital and Bronx Care, both 2 hospitals in the Bronx where we got a lot of trauma experience there as well. And then Geisinger Medical Center is in central Pennsylvania, in Danville. So just a brief description of what oral and maxillofacial surgery is. Here you can see oral surgeons are trained to recognize a wide spectrum of diseases, injuries, and defects in the head and neck, face and jaws, and the hard and soft tissues. They are also trained to administer anesthesia in the office, so we can always provide sedation for our patients in the office setting. And then we treat, common dental alveolar problems such as extractions, misaligned jaws, tumors and cysts of the jaw, and definitely dental implant surgery. All right, so why OMFS? So for me, I always, even before I went into dentistry, I was always tackling, should I do medicine? Should I go into dentistry? And I found that oral surgery gives you the best of both worlds. I think you're able to practice a lot of medicine within dentistry as well with oral surgery. So we always see it as a bridge between medicine and dentistry, so you can kind of pull from both to give a comprehensive treatment to your patients. So I thought that was important. With oral surgery and in dentistry as well, you can see immediate results and improvements in our patients right away. Patient comes in with a cracked front tooth. The story is they always have a wedding next week. They got to fix it. They got to get it fixed now. We're able to treat those immediately. If the patient comes in with an infected tooth or caries tooth that's giving them severe pain for weeks, they can't sleep, they can't eat, we can effect change immediately by taking that tooth out and draining the infection or abscess if there is one. So that's always important. That's a great part of what we do as dentists and surgeons. In regards to other surgical specialties within the medical field, oral surgery has a relatively low rate of morbidity compared to the other specialties, so that's also great. We also have great versatility in our practice. So as you can see here, listed here, there's a wide scope of practice within oral surgery. We deal with trauma, dental alveolar, TMJ, cosmetics, infections, pathology, head and neck cancer and microvascular reconstruction. So there's fellowships if you want to specialize in treating cancer patients as well. We do hard and soft tissue grafting, patients who have defects in the jaw, we can take bone from the hip or the leg, and we can reconstruct their jaws that way. As well, there's a lot of bank bone bottles on the shelves that have come a long way, so we can always use those as well, which avoids doing a separate surgical incision. Dental implants, commonplace for placing a lot of implants in our patients. As I said, anesthesia, we're trained in anesthesia for, about 5 months. We train with the anesthesiologist during residency. That gives us the ability to do IV sedations in our patients once we're done. So patients always want to have procedures done, but they want to be asleep for the procedure, so they usually get referred to the oral surgeon. Patients who present with, significant dental facial deformities or abnormalities. So we treat that with orthodontics or cleft lip and palate surgery as well. So those patients, again, immediate satisfaction. Patients who have either a huge underbite or they don't like the way their jaw comes together, we can effect change and realign their jaws and give them a more functional anesthetic outcome. So again, immediate change in our patients, which is what kind of sold it for me. All right. So the important part of being an oral surgeon is getting through oral surgery residency. So I wanted to kind of tailor this talk to oral surgery residency, because if you can get through that, that's like the most important thing. Once you're out of there, then things kind of change. But getting through residency, getting in and getting through it, I think is the most important part. So while you're in residency, as a resident, with your first year up to your final, your chief year, you'll be taking trauma and emergency calls. So while you're on call, the ED can call you for a variety of things. Common stay is any facial fractures, they'll call you for. If there's infections or abscesses in the head and neck region, they'll call you for that. Lacerations, so patients who either assaulted or slip and fall, who they can have cuts anywhere on their face, their lip, inside their mouth, they'll call you for that as well. Tooth avulsions is very common in the pediatric ED, so a lot of patients, the kids are running around, playing around, slipped and fell, they busted their front tooth, it came out. Those patients will come in, they'll always have the tooth, and we can reimplant that and stabilize it, and then follow them in the clinic as well. So that's a common call that you would get while you're on residency. So if you're on call, if patients that you get that night, if they need to be admitted, so you would admit those patients to the oral surgery service, or if we're a consulting service with the medical providers, we would still round on those patients. So as the person on call, you'll do your pre-round. So you'll round on each patient that's on your service that you're following, make sure orders are in, make sure they're getting their medication, make sure everything is prepped. If it's a pre-op patient that you're going to be taking to surgery that day, you got to make sure everything is ready, consents and all that stuff. So you're waking up at depending on how many patients you have and depending on what time your chief wants to round, you could be up at 4:35 trying to get all that done. And then when the whole team comes together, then you'll round on those patients and present each patient to the chief or the attending if they're rounding with you as well. Once you're done with rounds, usually the junior residents, they'll go to the clinic, and clinics usually runs from 8 to 5, where we'll see emergency walk-ins or scheduled patients and IV sedation patients that were scheduled. And usually the chief and the senior residents, usually they'll be in the operating room most of the day, so they'll go to the operating room for the big cases. Throughout each week, depending on the lecture schedule that your attendings have, you'll definitely have lectures that you'll attend and present at, different case conferences. For us, we had case conferences every Friday, so that would be the time where you would present all the cases that you did that week and the cases that are scheduled for the next week. And then sometimes it can be a big pimping session. The attendings love, asking, especially the junior residents, questions, and, they'll pick your brain. So you got to make sure you're on point with that. Most important thing as a resident, knowing that what cases are being presented, and especially the cases that you were part of and done, you want to read up on. The medical, the science, the procedure itself. So when you come to those conferences, you can show the attendees that you put some thought into it, that you show that you care about what's going on in the procedures that you're doing. That, it looks good for you, it looks good to the attendees, and that kind of gives you, a heads up and a bump up, if you wanted to get into future cases. If they see that you're actively learning and actively reading, that's a sure way to get you into the operating room and doing more cases. These pictures here was just a case that I did. This patient was assaulted. His left side of the jaw was actually broken in half. This kind of shows the reduction afterwards, after we put 2 plates here to reduce the fracture. On the most right picture, you can see this is what we call a stereolithic model. So this patient, he was super swollen when he came in. So we actually did this surgery in 2 stages. The first stage, we just wired him shut because he was too swollen to really do the full surgery. So while he was wired shut, we took a CT scan, which is like a medical grade imaging that you can see in 3 views. And with our plating company, they were able to recreate his jaw, as you can see here. And then I was able to actually pre-bent the plate before the surgery. So these are really thick plates. And if you do it intra-op while you're in the surgery, you have to, you have to bend it, you have to conform it, then you have to try it in the patient's jaw, see if it fits. If it doesn't, you take it out, bend it some more until you get a nice anatomical fit of the plate. So being able to do it beforehand saves you about a solid 45 minutes off the case. So that was kind of nice. So once we went in, I already had the plate bent, sterilized, and then once we reduced the fracture, the plate just fit on like a glove, and you can see here that the plate kind of fit nicely and it was well adapted. And then this is just the closure after the procedure. All right, so I'm going to go into a couple of cases here that we can kind of discuss, and at the end, if you have any questions about the cases, feel free to ask away. So patient case number 1, this is a 53-year-old male who presented to the ED, status post assault to the face outside a local bar. Just some prevalent medical history for HIV, Hep C, and cocaine use. He reported no known drug allergies. So upon physical exam, so when you're in the ED, when you get consulted to see a patient, you'll do a head-to-toe exam. Obviously, for oral surgeons, the most of our focus is going to be in the head and neck region. But you do want to check. If the patient was assaulted, you do want to check, even though the trauma team does it as well. But, it doesn't hurt for you to do it as well. Check their extremities, check their abdomen, make sure there's no other underlying fractures. Sometimes they got hit in the face, but they also got kicked in the chest, in the stomach. There may be an underlying rib fracture. So it's good to do a full head and neck exam, a neurological exam, just to make sure the patient is stable and you can kind of assess their baseline. And then you'll go through your vitals, your head and neck, you'll check the eyes, the ears, the nose, the throat. And then you can go into the mouth and see what's going on. So this patient, obviously, he got pretty beat up. So he had facial edema, which is just another word for swelling. So he was swollen, mostly on the left side. There was no cuts to the face, just a lot of bruising and ecchymosis, which is just like redness on the skin. Left V3 paresthesia. So that's an assessment of the neurological function. So when you have a fracture through the lower jaw, the mandible, most times it kind of goes through the inferior alveolar nerve, which is the nerve canal that gives sensation to the lips, the chin, the cheek, the tongue, and the teeth. So you want to assess that to see, preoperatively, did the patient have any numbness? And the patient did, because the fracture went straight through the nerve. So it's really important to assess that and document that, because most times after your surgery, they're definitely going to be numb just from stretching and manipulation. So you want to have that documentation that the patient was numb before, and then you can compare it to postoperatively. So MIO means maximal incisal opening. So that's just the measurement of how wide he could open, which is 30 millimeters. For most males, the most common opening is anywhere from 45 to 50. So he definitely does have limited opening. This patient was also edentulous. He was in complete dentures, so he had no teeth. Other than that, the physical exam was unremarkable beyond that. So this is a CT scan, and the CT scan, what's nice is they can give you a 3D image of the patient's jaw. So here you can kind of see in the 3D view a reconstruction, and you can see the fracture here. This is the left side, so you can see the fracture going straight through the mandible, at which we call the angle. So this is the angle of the mandible. And here you can see it's completely displaced and telescope, meaning they're kind of like this telescope side by side. So he definitely needs surgical intervention. It makes it more complex that the patient has no teeth, so we can't use his occlusion to kind of help reduce the fracture. So in this case, when you have patients with no teeth, you can't use their teeth to help you reduce fracture, so you have to do it purely by anatomic reduction. And here's just a Panorex, a dental x-ray, and you can kind of still see the fracture. And this is the nerve that's going through, and you can see the fracture goes right through the nerve, which hence he had that paresthesia on the left side. No fracture on the right side, and you can see he has no teeth as well. So the diagnosis for this patient is a displaced left angle fracture. And here's just a diagram showing the most common places for fractures to happen in the mandible. And you can see the percentages of frequency. So the angles here, which is where our patient had the fracture. So you can see it's a pretty common place for the jaw to break. So the treatment for him was open reduction internal fixation via transcutaneous approach. So basically we're going to open and expose the fracture transcutaneous. So we're going to go through the skin in the neck, and we're going to reduce the fracture, get it back anatomically, and then we're going to plate it, which is the internal fixation. So this is just a diagram kind of going through the procedure as far as the surgical approach. So there's different approaches that we take to access the fractures depending on where it is. So the submandibular approach, sub meaning below the mandible, is the most common surgical approach for approaching the mandible in terms of fractures and other procedures. So we're always mindful, and with any surgeon, you have to be cognizant of the anatomy. So your gross anatomy is extremely important. So you need to know where structures and vessels and nerves are anatomically, and that kind of guides how you're going to approach the surgery. So we always go approximately 2 centimeters below the mandible because your facial nerve, and it kind of courses through, and it varies from patient to patient, but on average the study shows it kind of courses below the mandible up to about 1.3 1.4 centimeters on average. And then at a certain point, it kind of courses back above the mandible once you get more anterior. So giving yourself 2 centimeters below the mandible kind of gives you a safe zone to know you're not going to cut right through the nerve. So this is the approach. So you make your incision. Then we get through the layers. The platysma is kind of pretty much the neck muscle. So you'll kind of elevate that and cut through it. Once we're through that, we're getting closer to where the nerve is going to be, getting to the deeper layers. So they have nerve stimulators that you can use before you cut through any deeper layers. So you can test it and make sure there's no twitching. You'll use it and you'll see the corner of the mouth twitch, and you'll see the little instrument light up. So if you see the mouth twitch, you're like either on the nerve or close to the nerve. And that can kind of, give you an idea, okay, I got to redirect my approach because I'm too close to the nerve. So either I got to go deeper or, change course just to get the nerve out of the way. Once you're able to get below the nerve and expose it, you can kind of retract it up out of the way. So here we're getting close to the mandible. We're getting deeper into the tissues. This is the gland, the submandibular gland. This is your facial nerve, which we call the marginal mandibular branch of the facial nerve. So that's coursing down. So you can see that. So this is a good anatomic view. This is the facial artery and facial vein. They always kind of run together. So these veins and this nerve is a problem. It's in our way, so we got to get through it. So this is another diagram showing you the approach. So we're getting through the layers. This is platysma. This is another investing fascial layer. Cranial nerve 7, that's the facial nerve. So we know once we're in this layer, we know it's going to be in the ballpark. So we got to, isolate it, get it out the way. Once we get to the facial vessels, we got to clamp them, transect them, and ligate them, and retract them out of the way so you don't have significant bleeding. Once you get through these vessels, then you're almost, you're almost a safe way down to the jaw, so you can kind of progress with your surgery. And that's what's just shown here. So once the vessels were transected, ligated, you can see they're kind of sutured. Then you can get down to the last layer, the periosteum, before you can get down to the bone. So now you can safely cut through that. We expose the bone, and now we can identify the fracture, where the fracture is. Once you've got down here and you identify the fracture, then you can start reducing it, manipulate the jaw, get it back into anatomical reduction. Once you like your alignment and you see that you have the fracture in the right spot, then you can pick out your plates and plate the fracture. And then once you're done plating, you can proceed with your closure, and you'll close in layers from deep to superficial just to eliminate the dead space. You don't want a big pool of empty area because that's just an easy way for a nidus of bacteria to form, and then the patient can get infected. So you want to get a nice watertight closure. You close, deep to superficial. This is closing the platysma, again, the muscle layer, and then you can close the skin. So this is just an intra-op photo of the patient after the reduction. So like I said, we went through the neck, so we went transcutaneously down to the mandible. Once we got down to it, you can see the fracture here. We were able to manipulate it, get it back into anatomical reduction since we don't have the teeth as a reference. So once we got into anatomical reduction, we placed a superior border plate, and this is a mini plate with monocortical screws. So pretty much you have two cortices of the bone. So a smaller plate goes through one cortex. This larger plate at the inferior border, we use bicortical screws. So it's a bit heavier, stronger plate, and the screws go all the way through. So through both cortices. And then this is just a post-op CT that we got, so you can appreciate the plate, inferior border plate, and the superior border plate with good anatomical reduction. And this is the Panorex. So you see good alignment. We have one plate above the nerve canal, the other plate below the nerve canal. And the patient, he went on to do really well. And typically, maximum 2 nights post-operative that they'll stay in the hospital. Some patients, depending on how early the case was, could go home the same day, depending on how severe the fracture was. All right, so case 2. So this was a 55-year-old male, no significant past medical history. He denied any medications. He had no allergies to any medications, and no previous surgeries. A social history, he was a smoker. The mechanism of injury in this patient, he was assaulted by multiple assailants with fists to the face. So upon physical exam, again, kind of just cut it down, just extra. So EOE is extra oral exam, so that's everything outside the face. So you can examine the face, see what's going on, see how swollen they are. You can manipulate the jaw to see if there's any mobility in the jaw. And then you can, again, assess if there's any nerve injury, any nerve deficits, any differences in sensation, which this patient had bilateral V3 paresthesia. So he had altered sensation on both sides of the jaw. And he did have a step deformity. So that means step deformity, you can kind of feel, if you feel your jaw now, you can feel it's nice and smooth. It's continuous. So when they have a fracture, you'll be able to feel a step defect. So either one part is up, one part is down, so you can feel a dip in something. So that's something you kind of, assess when you're comparing both sides of the jaw. Intraorally, so IOE is an intraoral exam. So he did have edema, which is swelling. Guarding trismus, so again, trismus, limited mouth opening. You could only open 15 millimeters, which is pretty significant. He had positive malocclusion, which just means his teeth didn't come together properly. So malocclusion, good occlusion, teeth come together, malocclusion, there's something off, something's wrong, which makes sense because he had a step deformity. So his mandible had a discontinuity. So, if you have one part of your jaw up, the other one down, your teeth, obviously won't come together properly. And because of that, the mandible was mobile. So you can assess the mobility. You can kind of shake the segments, and they'll jump a little bit because obviously it hurts, but you can feel the mobility in the segments. And he also had a fracture to the alveolus of the upper jaw. So kind of right above his front teeth, he had a fracture kind of going right through it with some laceration. So usually when you have a step deformity in the jaw, you'll always see a cut in the gums, a laceration in the gums where the fracture happened. So that can kind of direct your exam. So this is a CT scan again. This is the axial view. So as you can see, in an unbroken jaw, this would have been a nice continuous U formation. As you can see here, it's broken in 2 spots here, and then one back here on the right side. This is the left side, this is the right side. So he got pretty beat up. So this is a pretty significant fracture here. And this is a sagittal view. So it's just like a side profile view of the CT scan. And here, you can see the fracture kind of going right through the top of that. And this is a central incisor, so it's kind of going right above that. So we have to reduce that as well. And this is a 3D reconstruction of the CT scan. So you can kind of, appreciate the displacement of the fracture here. This is where we call the parasymphysis, and then back here more towards the angle, and you can see pretty significant fractures here. And this is, you can kind of see the break in the maxilla here above the apices of those incisors. So he definitely needed to be taken to the operating room for surgery. So the diagnosis here was open displaced left parasymphysis fracture and right displaced angle fracture, as well as maxillary alveolus fractures. And he had multiple broken down carious teeth. So we were going to take out those teeth at the same time in the operating room. So again, the treatment plan for this patient was open reduction internal fixation with maxillomandibular fixation of bilateral mandible fractures and extraction of the non-restorable teeth. So maxillomandibular fixation, which we'll always abbreviate MMF, that just means putting the patient into his natural bite and wiring him shut. So he's just wired shut, closed. And typically, depending on how severe the fracture, you can leave them wired shut from anywhere from 4 to 6 weeks. All right, so this is just the post-op imaging after the case. So this is 3D reconstruction again. So you can see we have the arch bars on the upper and lower jaws, and he's wired shut. And the symphysis fracture, we have 2 plates. And this is the mental, this hole is the mental foramen. So that nerve I was talking about before kind of starts back here and it comes out here before it goes into the soft tissue. So we're always mindful of that while we're doing the surgery. We can see it and we protect it, get out of the way, and then we can plate above it and below it. And then we had this patient wired shut after we took out all the non-resorbable teeth. And this is the angle fracture, so we put one fracture across here to stabilize that fracture. And as if you remember how it was into multiple broken pieces, so you can see pretty good anatomical reduction. We have that nice U shape again, good continuity compared to preoperatively. So pretty good reduction here. And this is pre-op and post-op. So here we kind of just stabilize the fracture back into place. And then we, with the arch bars and the wires, we're able to stabilize it that way. And he'll, like I said, he'll stay with those wires for about 6 weeks, which he did. All right, so case number 3. So this was an 18-year-old male, past medical history significant for schizophrenia. He presented to the hospital after alleged assault by fist. So when he presented to the ED, he had noticeable swelling to the frontal region, so big swelling in his forehead. And upon assessment, he was found to have a frontal sinus anterior table fracture, which we'll discuss. So you do have you have multiple sinuses. You have maxillary sinus down here, ethmoids around the nose. So they're pretty much air cavities, and you have one here, which we call the frontal sinus in the forehead region. So any major blows, any blunt hits to the forehead, that fracture, that table, the frontal sinus can be fractured. And you have 2 tables, which I'll show you on the scan, and then we can kind of discuss that further. So he had no LOC, which means loss of consciousness, which it's very important. So when a patient comes in to the trauma bay, they've been assaulted, you always want to know if they had loss of consciousness, because then they have to go through a whole general surgery trauma workup just to make sure there's no side effects later on. Because if they do have any side effects and you take them to surgery right away, then you don't know if it was from your surgery or it was from the injury itself. So you want to make sure they get a full assessment with the trauma team as well, just to make sure they're stable before going into surgery. All right, and neurosurgery saw him as well, because the frontal sinus, as I'll show you, it's pretty much, you have 2 sinuses, an anterior table and posterior table. The posterior table is just lining the brain as well. So if that gets fractured as well, neurosurgery definitely needs to be involved so it can become more significant. So they assessed him. They found that there was no intervention needed from their part. So he was just transferred to us. So here's the frontal sinus. This is an axial view of the CT scan. So you can see this is the frontal sinus. This is the brain matter here. So this is your anterior table. This is your posterior table. So he has a pretty significant defect of the anterior table. So that you can, once the swelling resolves, he'll have a major defect in his forehead that you'll be very noticeable. But you can see that the posterior table is still intact. So there was no need for neurosurgery to be involved. A lot of times, depending on how severe it is, both of these tables can be fractured. So then we'll go in as a joint case. So we'll go in with neurosurgery, and they'll do their part to kind of repair the lining of the brain that happens when this fracture happens. And then once they're done, we'll go in and repair the anterior table. So this is just a sagittal view. You can see how pretty kicked in that anterior table of the sinus is. So for function and cosmetic reasons, definitely a good reason to repair this fracture. And this is just a 3D view. So you can see pretty bad crushed injury to the frontal sinus here for this patient, but he had no other injuries elsewhere. So the diagnosis here was an isolated frontal sinus anterior table fracture with a right orbital roof fracture. So pretty much this is the orbit. So this is where, the globe, your eye, is contained. So he had a fracture right on the roof of the orbit here. So we're going to have to reapproximate that and repair that as well. All right. And the plan, we're doing open reduction internal fixation by bicoronal approach. So pretty much we have to, and I'll show you some pictures, we have to go from the top down. So we actually have to do, make an incision on the top of the scalp, and we'll kind of peel his skin forward to get access to those fractures. All right. So this is here I am making, first, we do our markings, and we kind of go in a wavy pattern a couple centimeters beyond where the hairline would be, just for cosmetic reasons. So when it heals, it won't show or scar as much. So we go in this kind of wavy pattern. So this is us marking the incision and then giving local anesthesia to our incision site. So here I am starting to make the incision. As you can see, the wavy design of the incision, couple centimeters above where the hairline would be. So once we make our incision, we'll start to elevate a flap. We're developing our coronal flap, and we're going to we get to a layer called the Sagittal plane, which is a pretty nice dissection, because once you're in that plane, everything kind of cleaves off really nicely and really easy. So you can get down to the fracture pretty quickly, because it kind of just peels off pretty quickly once you get to that layer. And this is us just further exposing the fracture, getting down to it. Okay. All right, so now we're at the fracture. So it's going to be in pieces. So we have to get access to the inside of the frontal sinus. So we'll kind of take those pieces off. And that's a tricky part. So when you take them off, you have to remember anatomically how they work, because we're going to put it back and plate it at the end. So once we take off those fragments, that gives us good access to inside of the sinus. Then we can clean out the sinus, because you'll have mucosa lining it. And a couple of things you want to do with this particular fracture is, first there's a duct that's on the inside that kind of goes into the nose. You want to assess if it's blocked or is it patent, is it open? So we can, there's different fluids that we can, inject right into the area where the duct is. And if we see it come out, if we drain, down into the nose, into the back of the throat, if we see that come out, then we know it's open, it's patent, it's not obstructed. If it is obstructed, then you have to do what we call obliteration. So we have to clear out all the mucosa that's inside the sinus. So we have to clean it out, curate it out, burr it out, make sure it's completely clean. And once you clean out all that mucosa, then we can fill it up. And there's different materials you can use to kind of obliterate. So we just kind of fill up the whole cavity with a material. It could be fat. It could be, a lot of times, the layer that we kind of peeled off at the end, right above the bone, is called the pericranium. You can use that tissue to kind of fill up the space as well. So there's different filler materials that you can use, but you just have to use something to fill up the space. Because if you don't do it that way, then they can get different complications down the road, meningitis. They can get a mucocele, which, is just different infectious cysts and processes that can happen further down the road. And they can, as far as the mucocele, those type of infections can happen, 10, 15 years later. So these patients you also want to follow up with to make sure they're doing okay long term. So in this patient, we tested the duct, and it was actually patent. He had good flow. It wasn't obstructed. So we still cleaned it out, burn everything out, just be on the safe side, but we didn't have to obliterate it. We didn't fill it up with anything because it was completely patent. So now once we clean it out, we're able to fit a mesh. And this mesh is just to kind of reconstruct the anatomy of the frontal bone. And it's very pliable. You can easily adapt it to the area, and then we can use some mini screws just to secure it in place. And then once done, then we can start to this is the pericranium flap that I was talking about. If we had to fill the sinus with it, we could use that to fill the space. If not, then we can as we start to close, we can start to reapproximate things for our closure. And we're starting to suture things up. So we're suturing layers. And then at the end for the skin, you can either, it's pretty much surgeon preference. You can either close it with sutures, or you can use staples, surgical staples, which we did here. And they're really easy to come off at the post-op follow-up, and they heal up pretty nicely. So as you can kind of see, now we have good reconstruction of the anatomy of the frontal sinus with that mesh, and reapproximated the bone pieces. This is another post-op view of the sagittal view. Here we go. So yeah, so we have good anatomic and adaptation all across the frontal bone there. There's another view of the axial view. And then this is just a 3D reconstruction. So we saw him in follow-up. He did really well. Incision healed up really nicely, and then we were able to take off the stitches. I think this was at the 2-week mark. We were able to take off the staples, and he did really well post-operatively. Okay, so last case, this patient case 4. This is a 23-year-old male. past medical history was special needs. He was on any medications, no allergies to any medications. Only surgery was a hernia repair and no social history. So his chief complaint, so this patient came to us, this is when I was in the Bronx, and his chief complaint was, I haven't been able to open my mouth wide most of my life. So this patient reported that he had limited opening as long as he could remember, and it just progressively got worse and worse. And these type of patients, you want to ask, did they have any trauma, any acute events that might have caused this? And he denied any trauma, no falls, no accidents, nothing of the sort. So now you got to kind of go into your physical exam and see what's causing it. So as surgeons, you're also problem solvers. So you got to kind of figure out what the problem is so you can diagnose it and then you can treat it. So this is just a physical exam. You had no facial asymmetry. So there was no signs of trauma or any defects in that sense. His TMJ joints, there was no clip or pops. There was no tenderness around the area. So there was no indication of any TMJ abnormalities or pathologies. We were able to assess his opening, which was about 20 millimeters, and that's just pushing him. You're able to push his jaw open just a tad and get him to 20. And again, he had multiple carious teeth that we can see, but with that limited opening, it's hard to really assess adequately inside the mouth because he just couldn't open wide enough. So this is a picture of how wide he could open. So you can see barely any opening to function and really, have a decent life, eating, talking, laughing, that little of an opening, it just wasn't adequate. This is a Panorex dental x-ray. So you can see just he had his impacted wisdom teeth. He had multiple broken down teeth, which makes sense. With that limited opening, he's probably not able to clean really well. No dentist can really see him to do anything because they can't really get in there to do anything. So it makes sense that some of these teeth in the back have broken down this way. So this is a CT scan in the coronal view, and this is kind of just straight on to the patient. So we can evaluate his condyles, the TMJ joint up here. Everything pretty much looks normal here. This is your coronoid. So this is pretty much the anterior extension of your mandible. So you have the condyle, which is the posterior aspect, then it makes kind of a loop into the coronoid process. And you can see this is kind of sticking up a little significantly here. So this is a standard view. So this becomes important. So again, this is the condyle. Like I said, then you kind of dip into a U. This is what we call the sigmoid notch in this area here. And then you kind of course anteriorly into your coronoid process. So typically the coronoid is either at, and this, because of the slice, you can't really see here, but this is where the zygomatic arch, pretty much your cheekbone, is coming into play. So typically this tends to, in most patients, be a little bit lower. But you can see here, this is a little bit elongated and extending pretty much, significantly above the arch on both. And this is the right side. So you can see that elongation of the coronoid process above the arch. This is the arch here. And the left side as well. So pretty elongated coronoid processes here. This is a cone beam CT that we took in the office just to get like a 3D view here. So you can see they're, extending well above. This is the right side, extending above the arch here. This is the arch, the cheekbone here. So the assessment here was trismus, in other words, limited opening secondary to bilateral coronoid hyperplasia. So those coronoid processes were just extending way too high above the arch. So when you open and close, the jaw has a hinge, it's like a hinge joint. So when it opens, that coronoid, it rotates forward a little bit, and when you open it wide, then it translates down and kind of dips under. But with that being so high above the arch, when he rotates, it's hitting it every time, so he can't get past that rotation any further. So that's why he can't open beyond 20 millimeters with assistance. So this is just a picture just to kind of depict the dissection and the approach that we take to get to the anterior part of the mandible. So you're making an intraoral incision kind of parallel to the occlusal plane here. Then once we can get down to the bone, we can kind of dissect and reflect upwards, and we just travel upwards until we get good exposure of the coronoid process. And you're kind of elevating the tissues on the lateral aspect and the medial aspect of the mandible. Once you get down to it, we can clamp it, and this is after I transected and cut out the coronoids. But once you expose it, you're able to clamp it And you have your other co-surgeon or your attending kind of holding that up for you, and then with your blade saw you can cut it. And once you cut it, the most important thing is the surgeon who's holding that piece, because if you're not holding it, once you cut it, the muscle that's attached to it can kind of just pull it up into no man's land, and then it's just gone. You're not going to be able to find it. And a lot of times, some people, they'll look, they can't get it, they leave it. Most times, the patient can still do okay with that, but if you can get it out, it's usually better to get it out, just to know that it's not floating around anywhere. And that's once you cut it, it's the easy part, but getting it out, because there's so much tenacious tissue attached to it, that you kind of got to cut, and you got to, we'll use electrocautery to kind of burn it off, and that kind of also helps us with the hemostasis, because there'll be a lot of bleeding because it's a muscle attachment. So cutting into any muscle is going to bleed a lot profusely. So using electrocautery to kind of coagulate the bleeding kind of helps. So that's the toughest part. That's this tenacious muscle attachment that you gotta cleave off and cut off before you can get that coronary process out of there. This is just another view of the two processes. And this is intraop. So remember, he could only open 20 in the chair when we initially saw him. So right after we cut the coronoids out, he was able to get to 50 automatically. So that was great. So that's going to change his life. The most important thing with these type of cases is the physical therapy afterwards. So we got this opening intraop. He's also asleep, so he's also relaxed. But now we know we can get there. We can get him there. When he wakes up, and the muscles, they're going to want to contract down, because they never have opened that far before. So they're going to want to contract and keep him constricted to that minimum opening. So post-operatively, we got to work with him, do physical therapy to stretch his jaw so the muscles can get used to opening that much. So that's, if not just as important as the actual surgery, or more, the post-op therapy. And this is just a post-op CT, so you can see where we did the cut here to get the coronoid process out. So now he has plenty of clearance from the arch to open and close. All right, so that's the 4 cases. So just to wrap it up, so the journey to DMD and OMFS. So kind of the process and the journey that I take, and most of you will take. From high school, you want to do well, obviously, in your SAT, ACTs. That's also a good time to shadow and volunteer. Obviously, with COVID, things have changed a lot since I was able to shadow and volunteer as a high school student. So these different sessions and shadowing sessions virtually are definitely going to be advantageous to you going forward. While you're in your undergraduate, obviously do well in your core sciences. The most important thing I can say is major in something that you enjoy, major in something that you're interested in. The misconception is, if you're doing, pre-health, whether it's pre-medicine or pre-dental, it has to be bio or chemistry or microbiome, some type of major like that, which is great. A lot of people do, the majority will do that, which is perfectly fine, but you don't have to. So that's the biggest misconception. I majored in economics. I was the only one in my class that majored in economics. And I think that stood out in terms of the admissions committee. So major in something that you're passionate, even if it's music, sociology, whatever it is, as long as you're passionate about it, you'll do well. That's what's important. And then you still have to take your core sciences on top of that anyways. So as long as you're doing well in those, then it's fine. So I would say the biggest advice in terms of picking a major is pick something that you're passionate about and that you want to major in. And then just do well in your core sciences. If there's a core science class that you didn't do so well in, then obviously, in terms of electives, pick up another science class just to boost up your science GPA. Obviously, the shadowing is an important part. Obviously, that dynamic has changed because of COVID and the dental volunteering, things like that. You want to get good letters of recommendation. Obviously, do well in your DAT scores. Personal statements is always important. So once you get that down, you got it tight, let someone or advisor or a colleague look it over, and get a couple of people to review it, look it over, just to make sure you got it tight and how you want it. And then once you do that, get a focus list of dental schools that you're interested in. Obviously, you don't have to apply to every single school out there, but get a good list, a good solid list of places that you're actually interested in, that you want to go, that you can see yourself being for 4 years, the school and the city and the location. So I think those two things are obviously important. Once you're in dental school, obviously you want to do well in your clinical and didactic courses. Class rank, if that school has it, is always important. Some schools don't have class rank anymore, so that's changed. The dynamic of the externships, that's also changing as well. So again, reach out to the different residency programs, whether it's oral surgery, ortho, endodontics, pediatric dentistry. See what they're doing to accommodate, externships or shadowing opportunities for dental students, because I know that dynamic has changed. So reach out to them. That's the best way to do it. And, they'll know your name. They'll see that you're interested. And, if they're open, they'll figure out something for you, whether it's virtual or whatever they can try to come up with. For oral surgery specifically, and I think in the different specialties, we have different standardized exams that the admission committees are using. The CBSE score is the one we use for oral surgery. That's kind of like it's almost like a minimized version of the step one, medical step one. So that's a very important exam, and they weigh heavily on that score now. It's like probably the number one. If you have to rank the level of importance of scores, letter recommendations, extracurriculars, I'll put CBSE score at the number one. Having been on the other side of interviewing candidates for oral surgery programs and talking with attendings, that score is definitely the number one thing that they look for. Then once they see that, if you're in the criteria that particular program is looking for, then they kind of go on to everything else that you have to offer in terms of your complete application. And again, for me, while I was in dental school, the most important thing is to spend as much time as you can in the oral surgery clinics. Get to know the residents there, get to know the attendings there. The chairman of that oral surgery department is very important. So when it comes time to applying, you definitely want to get a letter of recommendation from the chairman that's at your particular program. If you don't get that, it's saying to the other programs that the chairman at the school he's at didn't give him a letter of recommendation or her recommendation. Wonder why. So you don't want them, veering to speculation of why you didn't get one from them. So it's definitely good to, get as much exposure, as much face time with the attending and the residents as much as you can, so they know your face, they know you're interested, and they can really write a passionate letter for you. And that goes with everything, with any specialty, any subspecialty that you're going into. The better they know you, the more passionate they see that you are about their particular field, the stronger and more passionate letter of recommendation they can give you. And these are just some couple of cases. Like I said, I show you some trauma cases, some, pathology cases in terms of oral surgery. Like I said, it's a wide scope. We do a lot of things. That's what I love about this field. But at the end of the day, the bread and butter of oral surgery is still dental alveolar beyond residency. So once you're in private practice, you have your own practice or wherever you go, you'll still be doing a lot of wisdom teeth. That's mainstay. That's like the bread and butter of what we do. This is a case that this patient, she was missing her first molars here, and she also had impacted wisdom teeth. So I took out all 4 of her wisdom teeth and placed 2 dental implants at the same time for her. This is just another patient that she had a really broken down caries number 30 here. So with implants, with the different advancements in technology and the materials, we're able to place implants simultaneously. So I took the tooth out, and at the same time, I placed the implant, so she'll be able to be restored in 3 months. So beforehand, the idea was take the tooth out, graft it, let it heal, for a couple months, then come back and try to place the implant. Now, if the patient has enough bone and we can do it, and we're still mindful of the anatomy, make sure we're not too close to the nerve, we can take out the tooth and place the implant at the same time, which cuts down their treatment time from getting that crown, which is, at the end of the day, that's all they really care about, getting that crown. This is another picture. This is a case I did in the ED's patient. This was in Pennsylvania. She was driving, got in a bad motor vehicle accident, and kind of just went straight through the windshield. So she was in the trauma bay. She had other injuries, orthopedic injuries, hip injuries that they were reducing in the trauma bay as well. So they called me to assess this laceration, and she did have some jaw fractures as well. So I spent time cleaning out. You can see she was intubated as well on site. So here, it's hard to tell here, but going through a windshield, gravel into the ground as well, she had a lot of debris, a lot of glass in the wound. So I probably spent at least a solid 45 minutes just finding and picking out the glass, lifting up tissue, finding pieces of glass, washing it out really well. because that's the most important thing. You don't want to close these wounds with glass and foreign objects and debris in there, because it's just going to get infected. So cleaning it out really well is the most important thing, getting all the glass and debris out. And then once you do that, you can start to reapproximate the tissues and close it in layers and get good closure. So I did this, I closed it first, and then later that week, we were able to take her to the operating room to repair the fracture. So this is just after the closure in the ED, and then essentially we took her back and opened it up again, and then reduced the fractures and plated it. All right, so that's it for my presentation, guys. I'm definitely open to taking any questions. Feel free to connect with me on Instagram. If you have any questions beyond this, feel free to hit me up anytime. I'll be more than happy to connect with you and, help you guys out any way I can. I appreciate your time.
Thank you so much. We appreciate you taking the time to be here with us and for sharing all your cases. It was really interesting to learn about your experiences as well. So with that said, we have a few questions in the chat, if that's all right.
Yeah, absolutely.
Okay, thank you. So the first question is, do you have any advice for what you recommend students to do during dental school if they're interested in pursuing a specialty? You kind of touched about this a little bit, but I guess they're asking if you have any more specific advice.
Yeah, absolutely. So depending what year you're in, and it's never too early to start thinking about, what specialty you want to go to. Some of my colleagues knew right off the bat, right when they got in their first year, that they want to do this or that. A lot of us, after we go through the different rotations of the different specialties, then you can get an idea maybe in your second and third year. So whenever you do know what you want to do, you definitely want to start, like I said, start going in to those specialty clinics. The best thing to do, especially, you want to stay on top of your coursework. So in your second and third year, for us at UF, the third year was pretty much all clinical, not too much didactic. So you had more time on your hands once you got through your patients and you had some control of your clinical schedule. So if you're done early, or if you're done with your clinical cases, instead of going home for the day, walk over to the residency clinic. They're most likely still seeing patients. In terms of oral surgery, they're definitely there seeing patients or on a case. So that's the time when you have some free time to go into those specialty clinics. Let the attending, hey, I'm here. If it's okay if I shadow, or if there's any cases I can assist on or help on. That'll show that, most times they'll never deny you coming in. They want people to come in. They want people to be interested. So they love when students come by showing interest in their particular subspecialty. So that's the important thing. That'll probably be the best thing that you can do while you're in dental school, is connect with the residents, come friends with the residents. Most times they're, really amicable. They're, they're like down to earth. They can easily be reached out to. You can reach out to them, exchange numbers, get to know them. That's kind of a way in. And then, the chief or whatever, all right, he'll say, hey, I got a case, we're going to the operating room on this day, this such time. If you're free, definitely come through. And then, you get through the chiefs, and that's how you get to the attendings. And then for us at oral surgeons, they always had lecture conferences. And I think most other residencies, ortho, will have their own conferences that you're more than welcome to go to. Usually it'll be, for us, it was like 7 in the morning. So it was before clinic and classes start. So I'll just get there early, go to their conference, and then go to clinic or whatever course I had to take. So most of the residency programs will have some type of lecture or conference that you can go to that works in your schedule. So it's either going to be before your clinical session starts, or usually after or later in the day most times. So if you can get to those, and they're pretty consistent, usually every week, that's also a great way that the attending will see that you're there, especially like when they're early. The attending comes and like, oh, this student's here at 7 in the morning? Wow. Like, what's your name? So like, that's a way that they can see you more and more, even if you're not in the operating, even if you can't get into the operating room or the clinic session with the attendings, if they see you come to the conferences, that's even more, impressive to them, because you don't have to be there. It's a lecture conference. It's not like you're in an exciting case right now. So that's more impressive, and that'll stand out to them as well.
Thank you, Dr. Pierre. So another question we have is, how do you stay on top of your coursework during dental school and residency? And how did you retain the information? Do you have any advice for us?
That's a great question as well. So it's not easy. It's definitely tough. some of my friends are just blessed with I'll say practically almost photographic memory. They can just read something once and then it's just they just got it. I didn't have it like that, so I had to. You definitely want to set time because for us in dental school we had block exams. So you go 3 weeks and then you have like a slew of exams at that time from all your courses. So in undergrad I was able to get away. I was like a king procrastinator in undergrad, which I don't recommend at all in dental school. So I knew that and I cut it off day one because I didn't want to like start from behind the eight ball. So you definitely don't want to procrastinate because it's just too much information. You're not going to learn it well. Trying to cram for, especially for us, when you have 4 different, science courses that you gotta, study for and perform on, and their exams are all the same week. You just can't cram for it. So you want to give yourself enough time to study, and just come up with a schedule. You gotta come up with a written schedule. Say, okay, I'm gonna devote this many hours, to this subject, this many hours to this subject. If you write things down, I think you're more, you'll be more cognizant. You'll be more committed to sticking to that schedule. If you just kind of wing it, say I'll study when I can, or I'll study, after I eat, after I take a nap, then you'll never, be on track with it. So you want to give yourself enough time. Don't wait till the week of the exam to start studying for that course. Create a schedule, especially if you have multiple courses going at the same time. Create a schedule, and then come back to it. So you study for a couple hours, come back to it maybe the next day. So you can, let's say, gross anatomy. I studied gross anatomy for a couple of hours. Next day I'm gonna do biochem, but maybe before I start biochem, do a quick review of gross anatomy again, real quick, just so it's refreshed up, and then go into biochem. So for me, it took multiple, looking at the same material. I wasn't just reading once and it's just there. So I looked at it multiple times, create a schedule so I have enough time to review things and come back to it. That's the most important thing. Giving yourself enough time to review the material, and then just becoming able to multitask and juggle. I think, in dental school and residency, you'll just be forced to learn how to multitask and juggle multiple things going on at the same time, because that's really the only way. There's just too much going on, so you really have to develop that attribute in terms of learning how to multitask.
Thank you so much, Dr. Pierre, for your detailed response. Another question we have in the chat. What was the most challenging part of your residency?
I think the most challenging part is twofold, and there are different challenges. So I'll say every year is a different challenge. Your first year, your intern year, I think is the biggest challenge because you're getting thrown into just a new environment. You're straight out of dental school. You're going to this hospital now, and like, they're like, okay, you're on call. Like your first day, like, all right, here's the pager. Like, good luck, and like, so the first week, our program, they had a buddy system, so where one of the senior residents would be, on call with you, so they would kind of show you their role. So for me, that kind of helped. I saw him do 2 lacerations or handle 2 pages, and then so it was just 2 consoles, and then he handed the page over to me. He's like, all right, call me if you can't handle it, type of deal. So then, he goes home, and then I'm at the hospital, taking care of things. So that was the biggest, you kind of jolted into the fire, and you just got to put, your big pants on and like, all right, you want to prove yourself. You want to show that you can handle it. So, you're going to be reluctant to calling for help. You don't want to be that guy that called the help, his first week. So you figure things out, and then you make friends with people in the emergency room, the nurses. The nurses are great. They can be your biggest ally. So you definitely don't want to get on their nerves because they'll let you know about it. But you figure things out. You look things up. Sometimes you're reading about a case. YouTube and other like media platforms are great because YouTube has like a plethora of surgical procedures and how to do things, how to drain this abscess, how to do this laceration. So you can learn things that way on the fly as you're reading about it in your text, and then go down there and do it. So that was the biggest challenge, just because it's just a new environment. You're figuring out where stuff is in the ED. It's just new stuff that's being thrown at you. Patient comes in, they need your help. You got to assess all this. You got to admit the patient. You're trying to figure out how to learn the computer system. So that was the biggest challenge, I would say. And then in your chief year is a different challenge. Your experience, but now you have all the responsibility. You're responsible for all the cases that you do. You're responsible for your residents that are below you. So you're pretty much managing the clinic. You're managing the schedule. So it's a lot on your plate. So that's a different challenge. You're not taking as much of the primary call, pretty much they're calling you for backup now. So you're the backup, but you still have to be able to go in if they need you. You can't just say, I wasn't like this. So if they needed me, I got to go in, because if something happens, then it's still on me. It's always on the chief resident. So it's a different challenge because you have a lot more responsibility. But definitely your first year is usually, and in most places, in most scenarios, is the most challenging year because you're trying to figure everything out.
So your residency was only 2 years after dental school?
No, so for oral surgery, it's a 4-year program.
Okay.
So for oral surgery, you can also do internships, and then your match program is either 4 or 6 years. If you do the 6-year route, then you're doing pretty much the last 2 years of med school. So you'll start your oral surgery program, and usually most programs you'll go for like 6 months, 6 or 7 months on service, and then they send you to medical school for like 2 years, and then you come back and finish your residency program. Our program was like a 4-year program, so we didn't have the 2-year medical school component.
Thank you.
Thank you, Dr. Pierre. So the next question is, if you don't mind sharing, what were your stats like going into dental school and for residency? Like, what was your GPA and DAT?
So GPA going into dental school from undergrad. So going into dental school, I think it was a 3.6. My DAT wasn't great. I think I was averaging like it wasn't that hot. I think my DATs was like, and there at that time there was like multiple scores, but it was like 19 and 20s, which I don't even remember what the max is now, but it was like 19 and 20s, like your PAT, your other subject, it was like 19 and 20s across the board. So it wasn't the best, but it was decent that I was able to get some good interviews. So, but that's the thing, and that's a great question. So whatever, look at your stats, see what your GPA is, because at a certain point, by the time you apply, obviously you can't change your GPA score. It is what it is. So if you're at the beginning mark, you definitely want to do well and build it up, because it's always harder to build up, but it's easy to sink. One course can really sink you down. But if you can just keep a good, steady uprise, that's a good thing. So if you see that your GPA is not where you want it, obviously keep trying to build it up and do what you can to build it up. But then the score, your standardized test is where you can really attack it. Because if they see, all right, his GPA or her GPA is okay, but they just destroyed, whatever the test is, the DAT, then they're like, all right, they know the aptitude is there, right? Maybe they had a bad day in this course or whatever, but if you crush the standardized test, which is standardized across the board, they know that you're on equal ground with everybody else or better. So whatever you have a deficiency in, or you don't like where this is, or this could be better, just make up for it on something else on part of your application. For sure.
So kind of piggybacking on this question, how did you balance your time and like not become overwhelmed or burnt out?
At which stage, in dental school or undergrad, or?
I guess referring to each different stage.
So in undergrad, it was, so I got pretty involved, which I think also was a great thing, but you want to keep it balanced. You don't want to be too involved in like all these different clubs or organizations that you're sacrificing your time to study. So you want to keep that balance. But I think it's very important to be involved. Things you're involved in, you definitely want to try to get some form of leadership position in it. I think that's also a good thing. It definitely looks a lot better to be either, whatever it is, president, vice president, secretary, treasurer. If you have some type of official position in whatever organization you're in, that looks well. That looks well as well. So you want to keep that balance. And it was tough at times because, there's times where it's a lot of late nights, honestly. There's times where I wish I could study for this class right now, but I got a 5 o'clock meeting or 5 o'clock practice or rehearsal or something like that, or something going on, or we have this conference. So those different organizational things that take up your time, you have to kind of plan for that. So like I said, that's why it's good to have a schedule, good idea to write things down, so you can kind of, have some level of organization. So, okay, I got all these appointments and organizational things that I'm tied to and obligated to. that if you're in a, obviously you want to do well, you want to perform your duties to that organization and your the team members or whatever you're a part of, but still don't sacrifice your studies. And there are times where you're going to just be like, hey, guys, the test tomorrow, I really need to focus study for the exam, like, cover me for this meeting or whatever. I just can't make it. You have to make that call sometimes. You want to give yourself to the organization that you're part of, that you're passionate about, which is good, but you still got to look out for yourself at the end of the day, because at the end of the day, it's your grade, it's your GPA. No one's going to go take the test for you. And that was kind of the same thing across the way, like even into dental school. I had a job while I was in undergrad, and I just knew I wasn't going to work in dental school. I knew that just was not going to work, because the caseload was just going to be too much. So like I said, for us, since everything was in block, all our exams were in block. So like every 3 weeks, we know we're having all our exams. So I kind of just coordinated and structured my study schedule that way to know, what class I'm going to study for along the way, all the way until the exams come. And then pretty much, there's some dental organizations that I was a part of, like, SNDA, and you have like other IO and like other stuff. There's some dental organizations that you can be a part of and have, leadership positions in, and you just gotta, don't overload yourself. Like I was very involved in undergrad, a lot of extracurriculars, and I think that kind of also looked good as well in terms of applying. But once you're in dental school, you want to do well, because especially if you're trying to specialize in some specialty of dentistry, they're not going to care too much that you're in all these clubs. That stuff kind of dwindles down. That level of importance is like bar none. They want to see that you did well in your coursework, you did well in your clinicals, and whatever the boards. Obviously, I think they're pass fail. So you want to pass your boards, of course. So structure it that way. The level of extracurriculars kind of just goes down the higher you go. When I'm in oral surgery, it was just strictly oral surgery. Like there's just no time to do anything else in residency. It's just you're on call. When you're not on call, you're studying. When you're not getting paid, you're trying to study. So you're just always studying, you're always reading, because there's always a lecture, there's always a conference, there's always a question that's going to be asked at rounds or in a conference, and you want to look like you know something. Because the worst thing is like you're in front of everybody attending, asks you a question, you don't know it, and they just keep asking questions. Like you don't want to be, in that position. And it will happen. There's going to be time where it's just a late night, you're up all night, and they're not going to care about that. And they're going to ask you, all right, this and that, or what's this? What medication the patient on? What is it? Which you have to know, but you'll have slip ups here and there. So you just make up for it. Every day is a new day. The day didn't go the way you like. Just know the next day is another day to do it again and be better at it. So. In terms of managing your time, as you kind of move up from undergrad to dental school into specialties, those extracurricular side stuff usually, more likely than not, kind of just dwindle, and your focus becomes more tailored to the specialty or the school at hand.
Okay, thank you, Dr. Pierre. So I guess another question we have here is, what is one piece of advice you would give to future dentists that you wish somebody could give to you?
That's a great question. I would say in terms of dentistry, I would say, and being especially on the practicing side of things, and my wife is a dentist as well, so we can see, on the other side of, being in practice, just definitely make sure that you want to do it. I'll say make sure you're passionate about it. I've known colleagues, known friends that found it as, there's definitely entrepreneurship in being a dentist. You can be your own boss, things like that. Obviously, it's a stable career. You can make a decent living on it. But there are plenty of easier ways to do all that, to be a business person, to be your own boss, to be an entrepreneur. There's plenty of easier ways to do it. So definitely make sure you're passionate about it. For me, I knew within dentistry, I knew I was passionate about oral surgery, because even like the late nights, the 10-hour, 12-hour cases, not getting any sleep, I still wanted to do it the next day. So that's how I knew, like, this is what I want to do. So definitely make sure this is something you want to do. Don't do, whatever career you choose, don't do it because you think it's the good option or the safe bet, or parents want you to do it, or your friends are doing it. Make sure it's something that you want to do, that you want to be passionate about, because there's going to be a lot of tough days. There's going to be a lot of tough patients that, frankly, they don't give a crap about what you went through. They can come in, you're going to deal with whole types of attitudes, and you still got to keep calm. You still got to keep professional. Whatever bad day they had that they came with, you can't, spit it out back at them. You got to be the more professional one, keep it calm, collected, try to get them into a more happier mood. And, I get that a lot. They come in angry, maybe because they had a bad day or the tooth is hurting. They're pissed at everybody. They're pissed at the front desk. Now they're pissed at you once they get in the chair, even though you didn't do anything yet to them. So you're going to deal with all of that. So you want to make sure that this is something that you definitely want to do, and that you're passionate about it, before you fully commit to it. Because if it's about having a decent living, being your own boss, there's plenty of easier ways to do that, for sure.
Thank you for your response. Another question is, if you would have not specialized, do you think UF gave you enough clinical exposure that you would have felt prepared practicing right after without doing any more training?
Absolutely. So I think that's the best thing that, and I can't speak for other programs, but for UF, I think they really prepare you to just go out and start practicing in terms from a clinical perspective. Most of, UF, you definitely get a lot of surgical experience. You get a lot of experience in all things. But even a lot of my colleagues who they didn't want anything to do with teeth or extracting teeth, oral surgery, they didn't like doing oral surgery procedures, they were still good at it because we had so much experience about it. And a lot of them, take out their own teeth. They don't have to refer it out because they got so much training that they're good at it, and they're good at everything else. So I think from a clinical perspective, in terms of doing aesthetics, veneers, crowns, dentures, the whole scope of dentistry, extractions, you have just really, really prepared you to just go out and start practicing. And then from there, like I said, it's a ongoing field. There's always something more to learn. So even with all that knowledge, when you get out, you kind of realize you've only scratched the surface of what you're going to learn, what you're going to do. And that goes from any program. But UF, I feel, definitely gives you more than enough to kind of go out and start doing your own practice if you want it, or you join an associateship and you can learn under that senior dentist. And there's a few people that still go on and do like an AGD or a GPR to try to learn something different, or just to kind of hone your skills a little bit more. Because obviously you won't be as fast as you want to be, as you're going to be once you're done with dental school. You'll be good at it. You'll know what you're doing. But you're going to want to pick up your speed as well. So you can use a GPR and ADGD to do that and learn other different techniques as well. Or you can kind of figure that out while you're in practice as well and just kind of speed up that way. So, yeah, great question. But, yeah, UF, if I did it, I would have been more than prepared to go out and start practicing.
Thank you, Dr. Pierre. And to piggyback on this question, during your third or fourth year at UF, did you have to find your own patients, or were your patients provided for you?
They were provided for the most part. Yeah, I didn't have to. And actually, that's one thing when I was interviewing at places. That's one question I always kind of asked and try to figure out while I was interviewing at different programs to see, am I going out to find the patients on the street and give out cards, or I was not about doing all that if I could avoid it. But UF, they have a patient system where patients are assigned to you. You have a treatment coordinator, and you can sit down with her, and then she'll kind of work on your schedule and build your schedule up. And then there's different days when you're on the new patient rotation. So you'll have days where you're treating your own patients, and then there's other days where you spend the day on new patients. You just see new patients coming in, and those are your chance you can see what the patient needs. That's like your day to see the patient before anybody else does. And you can treatment plan it. You can kind of see what they need. You talk with your attending, and then, you can kind of just talk to your attending, hey, you saw this case. Can this be my patient? And they can assign that patient to you. So everyone gets that day to kind of see the new patients before they get dished out and assigned to all the students. So, and that's your kind of time where you can kind of more or less pick your patients out of the pool. This is a good case, or you need a root canal, or you need a crown. This patient has it, and you diagnosed it already. They can put that patient and assign it to you. So that's a good thing. So you didn't really have to go around fishing for patients. You can. So if you have family members or friends, you can definitely get them on your schedule. I did a filling on my mom. Just because she came to me and she needed it, but I didn't have to go like looking for patients. But if you have other cases, just for like specialty cases that you need, then they can do that. And then in terms of the other stuff, like you need your certain level of root canals and stuff like that. The endodontics, they have like a list that you'll get on, and then they'll sign it. It's almost like first come first serve. So they have a list. So once you're on the list, when they get to your name, they'll assign that patient to your schedule because you need a certain level of root canals. And then your bigs, like you'll get a big. So when you're in your third year, your fourth year, you'll have a clinic big, and they'll probably, depending on who you're connected with, if you're lucky, they're almost pretty much done with their requirements, and they may have a lot of, cases and patients that's still on their schedule that they can kind of hand off to you. And, a lot of times they've already gotten through a lot of like the perio and restorative phases, like, hey, this patient needs crown, this patient needs crowns, this patient needs this and that, which you need, obviously. So that's a good way as well. So between the clinic giving you assigned patients and like your bigs that can give you some of their patients that they don't need anymore. So you'll be more than okay with the patients.
Are there any other factors that you consider while applying for dental school that like you would recommend asking during your interviews?
Yes, I mean, when I was going around, one thing a good question is like that, the patient scheduling, and because there's some programs that you do have to, at least 50% of the time, you have to go and find patients and recruit patients. So that's an important question to ask. The board passing rate is a great question to ask because UF at that time, they had 100% for like the past 5 years. So that's a good indicator to see the level of preparedness that you'll be for board. So that was a question that I asked as well, their passing rates. And then you want to see, ask about the financial situation as well, the aid, obviously tuition's going up every year. So that's something to consider. For me, I was just so happy that, I'm a Florida resident, so UF, we got in-state tuition, which I think is key. Like, don't sleep on, whatever state you're in, unless you just really don't want to go to that program, or if you think it's just really not, the one for you, just don't sleep on your in-state schools. If you have an in-state dental school, that is a gem to decrease the amount of debt that you'll leave with. I know I don't know what it is now, but it's going up every year, so it's getting astronomical. But if you have a good in-state dental school, definitely don't sleep on that, because that can save you, hundreds of thousands in the end that you'll have to pay back. So that's another important thing I would consider. And then you look at the financial aid packages, see where you are. If you're trying to go to NYU, the tuition there is already crazy. I don't know what it is now. And to live there, the cost of living there is also crazy. If you're going to try and live in the city or live on your own, or you're going to get 4 roommates, so that's the thing to consider as well. UF, in-state tuition, and the area was relatively low cost of living, so that kind of worked out. So I thought about that stuff as well, because, you got to think about the debt that you're going to have to pay back when you get out of there, unless you're lucky and you got somebody that can write that check for you. But if not, that's definitely something to consider, and an important thing to consider in my book.
Thank you, Dr. Pierre. That was some good advice. So here I have, how do you deal with the failure or disappointment during dental school? How did you pick yourself back up?
So, I mean, you have to, you just have to. So like, in all walks of life, everything is not going to go your way. There's going to be bad days. There's going to be an exam that you didn't do well on, or acceptance if you didn't get into the school that you wanted, or things of that nature. The most important thing is to not give up. That's really the only true failure. You're going to get no's in your life. You're going to get knocked down. You're gonna get rejection here and there. It's it happens. It happens to the best of us. But the most important thing is what you do after that, what you do beyond that. Like I said, I don't know if I mentioned. So I didn't match straight out of dental school. So I did like an intern year in Brooklyn, and then match after that. So that day on match day, I was sitting in clinic, and then we get the response, all right, you did not match. Then it's like you take a moment and like whatever it is, it's a battery test or whatever you're dealing with, whatever you got going on. But for my situation, you take a moment. I'm in clinic. I got a patient that's in the chair as well at the same time. So I'm like, yeah, you got that moment, or you're feeling that moment of self-defeat and stuff like that. But you got to compose yourself. You're like, all right, so this just happened. You take your 5 minutes to grieve or whatever you want to do, be upset about it. And then you got to go, all right, what's next? All right, what do I got to do now? I was like, I got a patient chair. I got to take care of this patient because this patient needs my attention and my help. So once I'm done with that, I went to my clinic, and he was my clinic director, my clinic faculty. He was really great about it because I knew the next step. All right, I got to start applying to internships because I knew if, at that point, if it doesn't happen, internship is the best way to go in terms of oral surgery. Because pretty much you're working as a first-year resident, you're doing all the same stuff, you're with the residents, you're just not categorical. So that's like the best thing to do if you didn't match coming straight out of dental school. So I told my clinic director, hey, all right, this happened, I didn't match, I got to start sending out these applications to the programs for internship spots because it happens automatically. Everyone, once you get it, and there's hundreds of people that don't match because it's so competitive, everyone's on the email thread of sending out their application. So it's pretty much you got to get in the gate before those positions get filled up quick, and they'll get filled up that day. So he's like, go do what you got to do. And, so lucky for that. So I just went, and my mind's racing. I'm like, no time to grieve. I just got to hustle down and do the next step. I got to get on it and do what I got to do. So I sent everything out. Later that day, got the invitation from Brooklyn to come to their internship spot for the next year. So I did that, and it was a great year. Then matched after that. So like I said, everything may not happen when you want it to happen. There's going to be ups and downs, but if you really want something, if you're passionate about it, you take your time to relax. Realize what happened. Okay, this happened. This sucks. This sucks right now. I hate this feeling, but I'm not going to let it keep me down. All right. The only one that's going to pick yourself up is you. So you just got to get above it, get that, BS behind you and say, what's the next step? What do I got to do now? What do I got to do to get to my end goal? So that's the mindset I had. I said, all right, this is what I got to do. I got to do internship. That's the next step. Go apply, call, emails, calling people, do all that you got to do to get to the next step. And like I said, it may not happen when you want it, but if you really want it, you stay after it, just go get it. And it's definitely going to happen one way or another. So just, the only failure is to not do anything. So if you get knocked down, you get a bad grade, get up. Tomorrow's a new day to do better.
Thank you, Dr. Pierre. Unfortunately, that is all the time that we have for questions today. I just want to say thank you again so much for taking the time to be here with us and for answering all of our questions.
Absolutely. It was great. Great questions, guys. Great questions. Thanks for having me.
Thank you so much. And for everyone who joined today's session, the link for the quiz will be posted in our group meet. And yeah, thank you again, and we hope you have a great night.
Thank you guys. You guys